Hello, in this video, we're going to talk about ectopic pregnancies. This is an overview and introduction. Ectopic pregnancy means abnormal placement or position. Ectopic pregnancy is what the word suggests, which is a pregnancy in which the fetus develops in an abnormal place outside the uterus, typically in the fallopian tube. The clinical presentation of an ectopic pregnancy is usually a woman of reproductive age, let's just say 25 years old, presenting with acute abdominal pain with or without pervaginal bleeding. In any presentation that is similar to this, an ectopic pregnancy must be ruled out. Why? Because ectopic pregnancies are life-threatening. Comparing an ectopic pregnancy to normal, the female genital tract comprises of the vagina, cervix, the uterus, the ovary where ovulation of the female egg occurs, and then the fallopian tube here, which has many parts including the fimbriae and the ampulla. And this joins with the uterus. When the ovary ovulates and releases the egg, the female egg travels through the fallopian tube and becomes fertilized by sperm, if lucky. And this is fertilization. And the fertilized egg then typically implants in the endometrium of the uterus. And this is the beginning of a normal pregnancy. In an ectopic pregnancy, the fertilized egg implants somewhere outside the uterine endometrium, most commonly in the fallopian tube. And more than 95% of cases of ectopic pregnancy occurs within the fallopian tube, which is also known as the uterine tube. Other less common sites include the ovaries, the abdominal cavity, and the cervix. The clinical presentation of an ectopic pregnancy will be during the first trimester of pregnancy, so before 13 weeks gestation, let's just say. The clinical presentation of the ectopic pregnancy will depend on a few things. Number one, it will depend on where the ectopic pregnancy is located. Number two, it will depend if the ectopic pregnancy is symptomatic or asymptomatic. And three, if the ectopic pregnancy has ruptured or not. The clinical presentation of most patients is often that they are asymptomatic. But symptomatic ectopic pregnancies may include abdominal pain, and this can be very severe with vaginal bleeding. There can be nausea, the feeling of faint with shoulder tip pain, which indicates a ruptured ectopic pregnancy because of the irritation of the diaphragm, which will then refer the pain onto the shoulder. Finally, the other symptoms is amenorrhea, which makes sense because a woman who is pregnant will not menstruate. The physical examination will also depend if the woman is symptomatic or not, and whether the ectopic pregnancy is a ruptured ectopic or not. In a ruptured ectopic pregnancy, as you can imagine, there is tachycardia, fast heart rate, hypotension, low blood pressure, and there can be signs of shock and signs of peritonitis, which will indicate irritation of the peritoneum. But how does an ectopic pregnancy develop? Well, there are risk factors which increase the risk of ectopic pregnancy, which increases the risks of implantation along the fallopian tube. And these risk factors include a previous ectopic pregnancy, the use of intrauterine devices, chronic salpingitis, which is inflammation of the fallopian tube. Having tubal surgery also increases the risk. But 50% of patients actually have no identifiable risk factors. But some other less common risk factors include pelvic inflammatory disease as well as smoking. The main differential diagnosis of abdominal pain and PV bleeding in the first trimester of pregnancy can be divided into being a non-viable pregnancy or a viable pregnancy. A non-viable pregnancy includes a miscarriage, also known as a spontaneous abortion. Another non-viable pregnancy differential is a molar pregnancy. A viable pregnancy includes implantation bleed, as well as a subchorionic hemorrhage. And there are other differential diagnoses, including infections of the genital tract or even trauma. Investigations for a woman of reproductive age presenting with pervaginal bleeding and abdominal pain include a full blood count to check for anemia or infection, electrolyte urea creatinine to check for differentials such as kidney stones, check liver function tests to check for any biliary colic involvement. But the most important is serum beta HCG, as well as urinalysis checking for positive pregnancy test, beta HCG. Beta HCG is the hormone of pregnancy and is used to see if a woman is pregnant or not, and to monitor pregnancy in the early stages. In this scenario, it is important to take serial beta HCG, for example, every 48 hours. The reason for serial beta HCG measurement can be shown by looking at a graph, with the length of pregnancy on the x-axis, first trimester pregnancy, second trimester pregnancy, and third trimester pregnancy, and the y-axis is the beta HCG concentration, here on the y-axis. This is the normal trend of beta HCG during pregnancy. As you can see, beta HCG rapidly increases during the first trimester of pregnancy. It peaks around week 7 to week 10 gestation before it will taper off down. During this rapid increase of beta HCG in the first trimester, beta HCG should double roughly every 2 days, every 48 hours, if the pregnancy is viable. Further investigations that can be done must include an abdominal ultrasound and or transvaginal ultrasound to check for any complications in the pregnancy. The management of ectopic pregnancy will again depend on the woman, if they are symptomatic or asymptomatic, and whether the ectopic pregnancy has ruptured or not. The medical treatment can include watchful waiting if the patient is asymptomatic and if the ectopic pregnancy is detected early. The ectopic pregnancy might miscarry spontaneously. However, symptomatic ectopic pregnancy, or even those who are asymptomatic, can take methotrexate. Methotrexate is a type of chemotherapy agent, but it essentially works by inhibiting rapidly dividing cells, which makes sense because the fertilized egg comprises of rapidly dividing cells, and thus by taking methotrexate, the ectopic pregnancy can be stopped. So the proliferation can be stopped. Surgical treatment of an ectopic pregnancy is usually an emergency because the patient is hemodynamically unstable. This is always done in cases of a ruptured ectopic pregnancy. Surgical treatment can be either a laparoscopic or open laparotomy procedure. Laparoscopic is preferred. And then following this, if the pregnancy is within the fallopian tube, which majority of ectopic pregnancies are, a salpingectomy or salpingostomy can be performed. A salpingectomy is where the whole fallopian tube is removed. A salpingostomy is where only part of the fallopian tube is removed. Surgical treatment of an ectopic pregnancy is also done when there is a retained product of conception still within the female genital tract. Complications of ectopic pregnancy include a ruptured ectopic, which will lead to shock and even possibly death. Another complication includes a recurrent ectopic pregnancy, as well as methotrexate side effects, including nausea, vomiting, and also surgical complications, including infection.